Bailey. I'm Bibby Bailey. I am chair of the Independent Parkinson's Network, also known as IPN, and I serve as the executive director and CEO of the Parkinson Association of Alabama. It's a pleasure to have all of you here today as we are kicking off Parkinson Awareness Month. This month is dedicated to raising awareness for Parkinson's, to also sharing resources, fostering connections within the Parkinson's community. And at IPN, our goal is to work together and to share best practices, valuable resources, and to take collective action for improving the quality of life for those impacted by Parkinson's disease. Our current members of IPN, the Parkinson Association of Alabama, the Dallas Area Parkinson Society, the Houston Area Parkinson Society, Michigan Parkinson Foundation, Northwest Parkinson's Foundation, Parkinson Association of the Carolinas, Parkinson Association of the Rockies, Parkinson's Association of San Diego, Oklahoma Parkinson's Alliance, Parkinson's Resources of Oregon, Southwest Parkinson Society, Parkinson Foundation, Western Pennsylvania, Neuro Challenge Foundation for Parkinson's, and Parkinson Association of Northern California. On behalf of IPN, I would also like to thank our sponsors, AbbVie, Acadia, Ask Bio, and Blue Rock. Today's webinar is a great example of our IPN efforts, and I am excited to introduce today's speaker. Today's speaker is Dr. Joseph Imbs. He is a board-certified neurologist who is fellowship trained in both movement disorders and clinical neurophysiology. He is currently in practice at the Stanley H. Appel Department of Neurology at Houston Methodist. He provides comprehensive and compassionate care for patients who are affected by Parkinson's disease, dystonia, tremors, and other movement disorders, as well as patients with general neurology conditions including headache, migraine, and peripheral neuropathy. Dr. Imbs received his medical degree from Lincoln Memorial University DeBuss College of Osteopathic Medicine in Tennessee. He completed a residency in neurology at Beaumont Health in Michigan, a clinical neurophysiology fellowship at the University of Texas Health Science Center in Houston, and a movement disorders fellowship at Houston Methodist Hospital. He is the author of many publications, and he is an active member of the Houston Area Parkinson Society Medical Advisory Board. So Dr. Imbs, thank you for joining us today, and I'm going to turn it over to you to get started. Thank you.
Thank you, Bibby. Can you hear me okay? I'm going to assume yes, unless someone starts shouting at me. But thank you for that kind introduction. As Bibby said, my name's Joe Imbs. I'm a movement disorder doctor here in Houston. And today we're going to talk a little bit about the history of Parkinson's disease. So hopefully everyone can see my screen. And what's going on here? Okay, here we go. So we'll just get going here. I think this is working. So patients often ask me how their disease is going to progress, to which I typically reply that no one really knows the future. We have an idea regarding how large groups are going to progress in a particular situation, but usually can't speak to each individual's personal experience. So I usually try to relay outlooks that I believe in and try to practice myself, that it's always wise to hope for the best, but to prepare for the worst, that we should attempt to control the things in our lives that we can, and that we should let go of the things that we cannot. I frequently tell my patients that if we want to make our best guess as to where things are going, we have to look a bit back to look forward. If we understand where we've been and how we've been progressing, then we get a better idea of how we can expect things to continue in the future. So I think that same principle can be applied to understanding just how far we've come in the understanding of the pathophysiology and the treatment of Parkinson's disease. And though sometimes I know it feels like that medicine's moving at a snail's pace, when we look at how far we've come, I see there's great hope in where we can still go. So for the next hour, we're going to review a little bit of history here. So Parkinson's disease has unfortunately been around for a very long time, and much of the understanding of the disorder has come through observation. Going way back, early descriptions of Parkinson's disease seem to date back to traditional Indian texts. For example, something called the Charaka Samhita, which is a Sanskrit text on Ayurveda, which is an Indian traditional medicine from approximately 1000 BC, as well as from ancient Chinese sources that provided descriptions of a disorder of slowness, of tremor, of rigidity, and of gait changes. Officially, this disorder was first described in modern Western medicine in 1817 by James Parkinson, a name everyone here is likely certainly familiar with, who was a London-based physician, geologist, and political activist, first publishing his observation in an essay called On the Shaking Palsy, with the shaking palsy referring to tremors, shaking, and rigidity, palsy. This was the original term used for what we now call Parkinson's disease. Despite the limited medical tools of his time, his clinical observations allowed him to identify the constellation of symptoms that have come to be pathognomonic for this disorder, specifically slowness, resting tremor, muscle rigidity, and Parkinsonian gait changes. Interestingly, Parkinson didn't have a very clear understanding of the underlying pathology of this disorder, and it wasn't until decades later that more information about the brain's involvement, particularly the substantia nigra, would emerge. More on that to come. Ultimately, Parkinson hoped that by describing this condition in detail, it might lead to an effective treatment, of which that would only partially become true until the 1960s with the introduction of levodopa. Also, more on that later. So despite being profoundly impactful on how we understand Parkinson's disease today, Parkinson's essay didn't really receive widespread recognition during his lifetime. It wasn't until the 19th century that a French neurologist, Jean-Martin Charcot, expanded on Parkinson's work. So this lovely gentleman in the corner here is Jean-Martin Charcot. He lived from 1825 to 1893 and was a renowned French neurologist, often considered the father of modern neurology. He's interestingly not only known for his discoveries, but also for having taught several other famous neurologists, including some of those pictured here, Sigmund Freud, Joseph Babinski, and Gilles de la Tourette, whom some of you might have heard also. Charcot actually rediscovered Parkinson's essay in the mid-19th century and found it highly valuable for further understanding a pattern of movement disorders he was observing in his clinic, ultimately expanding on and adding precision to that initial description by Parkinson. Charcot's first important contribution to the study of Parkinson's disease was his differentiation of the disorder from other tremulous disorders, specifically essential tremor and the tremor that can come with multiple sclerosis. Additionally, he identified that the shaking palsy, in fact, was not an accurate name for the disorder. The tremor is clearly not a necessary feature of this disorder, just a potential symptom that can present with varying degrees of severity, thus beginning the understanding that Parkinson's disease lives on a clinical spectrum, one where each person has their own individual path to follow. Ultimately, Charcot officially named the condition Parkinson's disease and differentiated it from other movement disorders. So a few other key players to note who made significant observations on this journey of discovery in Parkinson's disease include the neurologist William Gowers, who was working in London and contributed an important study of Parkinson's disease demographics in a paper called The Manual of Diseases of the Nervous System, describing his personal experience with around 80 patients in the 1880s, at which time he identified the slight male predominance that still holds true today. A Doctors Riker and Meeg of the French Neurologic School, where much information came from during this time period in roughly 1895, provided clinical and morphologic details of the progressive stages of Parkinsonian disability, and the former provided a bunch of drawings and statues that remain amongst very important pictorial documents that we still have available today. Joseph Babinski began to comment substantially on the motor fluctuations intrinsic to the disease in around 1921. Also in the 1920s, a Dr. Brassard first proposed damage to a part of the brain called the substantia nigra is the anatomical seat of Parkinson's disease. And some neurologists, Dr. Tretikov and Foy, as well as a neurologist, Dr. Nick Galesko, pursued further pathologic studies of the midbrain and the relationship to the disease. The most complete early pathologic analysis of Parkinson's disease and the clear delineation of brainstem lesions was first performed in 1953 by doctors Greenfield and Basquinet. So jumping back, another key observation in addition to this idea of idiopathic Parkinson's disease was established when Charcot and his students identified variants with features that were atypical of classic Parkinson's disease. These were termed Parkinson's disease without tremor, Parkinson's disease with extended posture, and Parkinson's disease with hemiplegia. These cases are of historical interest because they're likely examples of disorders that would later be grouped under the term Parkinsonism plus syndromes, or now atypical Parkinsonisms, that include progressive supranuclear palsy, corticobasal syndrome, multiple system atrophy, dementia with Lewy bodies, and frontotemporal dementia. We're not going to focus much on these today, but suffice it to say, for those who aren't familiar with these disorders, that these are similar to Parkinson's disease, but with more baggage. At the end of the day, if no one said this lately, Parkinson's disease generally has no statistically significant impact on lifespan. It's a disorder with lots of potential symptoms that will potentially need to be dealt with, but life will go on and there's still good life to be lived. Atypical Parkinsonisms, which again, we're not going to focus on today, unfortunately, do not have the same prognosis. So quickly, a few other key events in the history of understanding Parkinson's disease worth noting include post-encephalitic Parkinsonism in the early 1900s and the impact of MPTP much later in the 1980s. So the 1916-1917 influenza epidemic, closely associated with the Spanish flu pandemic, played a significant role in the emergence of a neurologic disorder called post-encephalitic Parkinsonism, or encephalitis lethargica. This condition presented with symptoms resembling Parkinson's disease, including tremors, rigidity, bradykinesia, and postural instability, along with additional symptoms like behavioral changes, eye movement abnormalities, and cognitive decline. First described by an Austrian neurologist, Konstantin von Economo, in 1919, post-encephalitic Parkinsonism became a global concern affecting tens of thousands of people. While the exact relationship between the flu virus and this condition remains debated, it's believed that the viral epidemic triggered this neurologic disorder. Patients often suffered from psychiatric symptoms and severe eye movement disturbances, like something called oculogyric crises, suggesting that this condition affected multiple brain areas beyond the substantia nigra, where Parkinson's typically originates. That having been said, many survivors developed a very chronic Parkinsonism that required lifelong care. At the end of the day, this disorder helped neurologists understand that Parkinsonism could have various different triggers: infections, toxins, traumas. And these cases helped pave the way for the discovery of dopamine's role in motor control and the development of levodopa as a treatment in the 1960s. By the mid-20th century, post-encephalitic Parkinsonism largely disappeared, and there have been no further epidemics of this magnitude. However, its impact on neurology and Parkinson's disease research remains profound, again, highlighting this role for environmental factors that we talked about, so a cause beyond the genetics of Parkinson's disease. Next, in the early 1980s, the discovery of MPTP, a neurotoxin that induces Parkinsonism, marked a major breakthrough in Parkinson's disease research. It was discovered by accident when young drug users in California developed symptoms nearly identical to Parkinson's disease after injecting synthetic heroin contaminated by MPTP. This was the first time a neurotoxin was linked directly to Parkinsonism. MPTP selectively damages these dopaminergic neurons, again in the substantia nigra, the same region of the brain affected in idiopathic Parkinson's disease. Once metabolized by monoamine oxidase B into MPP+, it causes this irreversible Parkinsonism. This discovery revealed the significant impact of environmental toxins on the onset of Parkinson's-like symptoms and opened new research avenues into things like pesticides, herbicides, and other toxins as potential causes of this disorder, in addition to things like the viral infections we discussed earlier. So MPTP also provided scientists with this reliable animal model for Parkinson's disease, as MPTP-induced Parkinsonism in primates mirrors the symptoms and pathology of human Parkinson's disease. This model has become the gold standard for studying the disease and helping to test neuroprotective strategies and develop treatments such as deep brain stimulation, which we'll talk about a little bit more later. Moreover, MPTP has deepened our understanding of Parkinson's disease pathophysiology by illustrating how things like mitochondrial dysfunction, oxidative stress, impaired energy metabolism all can contribute to the degeneration of dopaminergic neurons. One last discovery to note, in 1967, regarding the natural history of Parkinson's disease, the morbidity and clinical progression of Parkinson's disease was studied in this important article by two gentlemen, Hone and Yar, in which their internationally recognized staging system was first introduced. The staging system, which I ultimately think is only modestly helpful overall clinically, is anchored in the distinction between unilateral, stage 1 disease, or bilateral, which can be stage 2 through stage 5 disease, with development of postural reflex impairment at stage 3 as a key turning point in understanding the disease's clinical significance. So what have we learned? Overall, there appears to be a two-hit mechanism in idiopathic Parkinson's disease, with people born with some genetic predisposition to developing the disorder. And then there's this lifetime cumulative risks of things that they may have been exposed to that then start this self-perpetuating cascade that, while possibly all different, we all call Parkinson's disease. To me, this heterogeneity of all these potential etiologies is likely what leads to the vast heterogeneity of the disease as we see it, and probably in turn the difficulty finding a disease-modifying therapy. So with regards to pathology, the big drive behind all this appears to be a protein called alpha-synuclein in idiopathic Parkinson's disease. I won't bog this talk down with pathophysiology, but suffice it to say that the discovery of alpha-synuclein in Parkinson's disease represents a major milestone in our understanding of the disease. Alpha-synuclein is a protein found in the brain, and its connection to Parkinson's was identified in the late 1990s. It's found in other places as well, and I won't harp on this, but there is something called an alpha-synuclein skin biopsy that we look at that kind of is a more contemporary test that sometimes can be considered. So researchers were investigating the brains of patients with Parkinson's disease and noticed that Lewy bodies, these abnormal clumps, were found in brain cells of these patients composed primarily of this protein alpha-synuclein. The clumps interfere with the normal functioning of the brain cells, particularly the dopaminergic neurons that help control movement. As these neurons deteriorate, the typical symptoms of Parkinson's, the tremor, the rigidity, the bradykinesia, the gait changes would all start to appear. The discovery was crucial because it gave scientists a molecular target to focus on. Understanding how alpha-synuclein behaves, how it misfolds and aggregates in the brain has led to more advanced research into potential theories aiming to slow or stop the progression of this disease. So one theory of, I guess just quickly worth mentioning also, of this alpha-synuclein is something called the Braak staging hypothesis, proposed by this gentleman, Heiko Braak, a German neuroanatomist, presenting this information around 2003, where he hypothesized that this alpha-synuclein can enter the gut with patients first developing constipation, then marching up the vagus nerve and through the olfactory bulbs, so possibly developing some smelling changes, loss of sense of smell, and then marching up the medulla and the pons, affecting the reticular activating system, which can lead to this thing we call REM sleep behavior disorder, where we act out our dreams overnight, and then ultimately up to the midbrain, where the substantia nigra again is located and dopamine is produced. And with 50% loss of dopamine production, we start to develop the more profound motor symptoms of Parkinson's disease. And I guess quickly of note here on the top is just a picture of a Lewy body. And underneath the top picture is an example of some depigmentation of this substantia nigra in the midbrain, with the bottom one being what a normal substantia nigra would look like in a healthy patient. So moving past the pathophysiology on to the evolution of the diagnosis. So as we noted before from the very beginning, the diagnosis of Parkinson's disease has been a clinical one. It's based on close observation and based on the specific clinical constellation of slowness in conjunction with varying degrees of rigidity, resting tremor, and Parkinsonian gait changes. That's typically stiff, slow, narrow-based, forward stooped, with decreased arm swing and reemergence of that resting tremor. This is often, again, predated many years with varying degrees of non-motor symptoms that could include that anosmia or loss of sense of smell, that REM sleep behavior disorder, or acting out our dreams overnight, or constipation. To this day, movement disorders are overall unique in medicine and to some extent in neurology, in that they're so heavily weighted on the clinical component of the diagnosis, on a good exam and on a good history. That having been said, there's one older test that's worth discussing as important in the history of Parkinson's disease, and that is the DAT scan. So the DAT scan, or dopamine transporter scan, was approved by the European Medicines Agency in 2000 and by the FDA in 2011. It represents a milestone in Parkinson's disease diagnostics by providing objective imaging evidence of dopaminergic neuron loss. It works by utilizing single photon emission computed tomography, or SPECT imaging, and radiopharmaceutical agents to assess the health of dopamine producing neurons in the striatum, a part of the brain that it's affected in Parkinson's disease and other related conditions. So basically, the DAT scan, when that test is done, the patient's injected with this iodinated contrast, something called I-123. It's injected in the bloodstream. It specifically binds to these dopamine transporters that are responsible for dopamine reuptake on the surface of the neurons in the striatum. After the injection, the patient waits somewhere along the lines of 3 to 6 hours for that radio tracer to distribute and bind to those dopamine transporters in the brain. And then this is followed by that SPECT imaging that can detect how much dopamine transporter activity is present in the striatum, which is typically comma-shaped, like in the left picture there, indicating a normal dopamine transporter density. In patients with Parkinsonism, the uptake will be reduced, mainly in an area called the putamen, or the bottom part of the comma. This test is best used to distinguish between Parkinson's disease and essential tremor, the other most common movement disorder, but it cannot differentiate between other subtypes of Parkinsonism, like those atypical Parkinsonisms. It's also worth noting that it's a test that's not without its false positives and negatives. So I mentioned a little bit that alpha-synuclein skin biopsy. That's a bit of a newer test, but I won't belabor the point on that one. And we'll talk more about medical treatments, because again, the diagnosis of Parkinson's disease to this day still continues to be very much clinical. So again, circling back to 1817 in his monograph, Dr. Parkinson had one chapter entitled Considerations Respecting the Means of a Cure. Similar to the hopes of today, he expressed hope to find a cure and to identify a disease-modifying treatment. Also similar today, he advocated for early therapeutic intervention when signs were largely confined to the arms without balance and gait impairments. Unlike today, his recommendations reflected the therapeutic approaches of the early 19th century, specifically advocating bloodletting from the neck, followed by vesicatories to induce blistering and inflammation of the skin. Small pieces of cork were purposefully inserted into the blisters to cause sufficient quantity of purulent discharge. And all of these efforts were designed in his hopes to divert blood and inflammatory pressure away from the brain and spinal cord, and in this way decompress the medulla that Parkinson considered the seat of neurologic dysfunction. This did not work. So moving forward again to Charcot and Gowers in the late 1800s, in reviewing the pharmacologic treatments for Parkinson's disease, in 1872, Charcot stated, "Everything or almost everything has been tried against this disease. Among the medicinal substances that have been extolled and which I myself had administered to no avail, I need only enumerate a few." So the main treatments, or the few that he enumerated that he believed in, were belladonna alkaloids, which were discovered as the first established treatment in Parkinson's disease. These agents are centrally active anticholinergic drugs that later would be understood to affect the cholinergic dopaminergic balance in the striatum and thereby improve Parkinsonism. So basically, with the decrease in dopamine that happens in Parkinson's disease, there's a compensatory increase in acetylcholine. These anticholinergic medications would block acetylcholine and in turn hopefully return some semblance of balance between the two chemicals. Of the many centrally active anticholinergic agents of this particular era, Charcot's preferred product for Parkinson's disease was hyoscamine, a plant-based agent that was prepared as pills, usually powder rolled into bits of white bread or as a syrup. And in addition to this hyoscamine, an ergot-based product, Charcot advocated an overall program of rest, reduced stress, which was generally kind of recommended for all primary neurologic disorders of this time period. So interestingly, in rejecting most medicines, Charcot advocated vibratory therapies for the management of Parkinson's disease. He'd observed that after long carriage or train or horseback rides, patients with Parkinson's disease experienced a marked symptom amelioration. He therefore developed a replication device to provide rhythmic movement by an electrically powered shaking chair, something he called the, I'm going to pronounce this wrong, but the Fauteuil trépidant. His student then, Gilles de Tourette, who we mentioned earlier, fashioned a helmet that was more easily transported and vibrated the brain rather than the body. Interestingly, some of these theories around vibrating techniques, though not proven, are still being looked at by some today. So, a more unusual and hazardous early treatment of Parkinson's disease involved the use of a suspension apparatus to stretch out the spinal cord. Developed in 1883 in Russia, this apparatus gained infamy when Charcot examined its safety and efficacy in a variety of different disorders, including Parkinson's disease. So using gravity and the patient's weight to put excessive vertical traction on the spinal cord and nerves, the therapist hoisted the subjects up into the air with a pulley and a harness that slipped under the chin and the occiput or the back of the head. This, not surprisingly, was not particularly helpful and led to some serious side effects, lots of stress for the patients, and was quickly abandoned. Gowers, Charcot's British contemporary around the same time, tried similar strategies. He also tried rest and hyoscamine and arsenic and morphia and hemlock and opium and Indian hemp or cannabis. Of these today, cannabis is still known to have some dopaminergic activation properties, but opium and the other opioids and opiates, they affect the motor system in a generalized sedative manner without any direct or primary dopaminergic involvement and have been abandoned as any type of treatment strategy. So through the mid-20th century, the treatment of Parkinson's disease remained largely static. There's a wide variety of centrally active anticholinergic drugs developed and used, including trihexyphenidyl or Artane, which are still used today, though often limited by side effects. The emphasis of this period really remained on supportive therapy, physical therapy, management of other symptoms like hypersalivation, like decubitus that could develop if patients weren't moving, or infections that could come as patients became more ill. So dopamine was first synthesized in 1910 by two gentlemen, G. Barger and J. Ewens. In the late 1950s, two seminal discoveries occurred. First, that dopamine originates within the brain, specifically that area called the striatum that we talked about, and the development of something called the risperidone model, later used to be the first model of Parkinsonism that was reversed by levodopa treatment. So bearing that in mind, it took from 1817 to the 1950s to identify that dopamine was the driver in the control of movement. Circling back to our brief discussion of the post-encephalitic Parkinsonism, it was just after this time, then in the 1960s, that striatal dopamine depletion was identified as the cause of Parkinsonism. So with the knowledge that levodopa was the natural precursor to dopamine, Dr. Berkmeyer injected levodopa intravenously for the first time to Parkinsonian patients in 1961. The anti-akinetic effects or the anti-slowness effects were quickly published, where he said, quote, bedridden patients who were unable to sit up, patients who could not stand up when seated, and patients who, when standing, could not start walking, performed all these activities with ease after levodopa. They walked around with normal associated movements, and they could even run and jump. The voiceless, aphonic speech, blurred by polyalia and unclear articulation, became forceful and clear. So subsequent open label levodopa trials with oral preparations in the late 1960s confirmed both short and long-term benefits. and double-blind placebo-controlled trials followed. These reports launched levodopa's establishment as the premier agent to treat Parkinson's disease symptoms and signs. It's also worth noting a gentleman named P. Holtz, who discovered the enzyme dopa decarboxylase, and documented that levodopa was synthesized to dopamine through its action. This led to the later creation of the dopa decarboxylase inhibitors. So carbidopa was first synthesized and introduced in the late 1960s by this gentleman. It became an essential part of Parkinson's disease treatment when combined with levodopa to enhance its effectiveness. So the combination of carbidopa and levodopa was first approved by the FDA in 1975 under the brand name Sinemet. Carbidopa works by inhibiting the enzyme dopa decarboxylase outside of the brain, like we said, preventing levodopa from being converted into dopamine prematurely in the bloodstream. So this allows more levodopa to reach the brain where it can be converted to dopamine, thus improving Parkinsonian symptoms while reducing the peripheral side effects, specifically nausea and vomiting, that can be associated commonly with levodopa alone. Thus the original name Sinemet, sin without emesis, without vomiting, without throwing up. So jumping ahead, it's worth noting medications like Rytary, which is a combination immediate and controlled release levodopa that was approved by the FDA in 2015, and more recently Crexont, approved in 2024. I'm sure many are familiar with these, and they've marked a pretty big advancement in levodopa, which again has long-standing been the gold standard treatment for Parkinson's disease, with these being maybe better avenues of giving this medication in a more sustained fashion. So other medicines running through these dopamine agonists, including ropinirole, pramipexole, the rotigotine patch, these were introduced in the 1970s and the 1980s. These medications worked by stimulating dopamine receptors directly, mimicking the effects of dopamine without needing to be converted into the brain, like levodopa needs to be converted. So from a benefit standpoint, it's effective in reducing motor symptoms, particularly in the early stage of Parkinson's disease. And there's some old thoughts about how this could be used to delay the start of levodopa and possibly delay some levodopa-related complications. The side effects of these dopamine agonists, again, include nausea, can include sleepiness or sleep attacks, can include hallucinations or impulse control disorders. So it makes people feel good, but maybe a little too good, where people can then become more hypersexual, more inclined to gamble, more inclined to shop, things like that. Of note, there was a study called the Delayed Start Study that took place in 2019, looking at patients started on levodopa versus on these dopamine agonists over a 40-week period, following which everyone was then started on levodopa. And at the end of an 80-week period, the punchline is that there was no difference statistically between the two groups with regards to symptoms, but the patients who were on the levodopa earlier actually scored better in motor and in quality of life scores all the way through. So this delayed start with dopamine agonists is still discussed by some, though most consider starting levodopa as the first line agent, in part based on that study. So amantadine, the history of amantadine is of interest because of its serendipitous discovery as an anti-Parkinsonian agent. It was developed as an antiviral agent, also in the 1970s and 80s. It was used widely in nursing home populations where a very astute physician, a gentleman, Dr. Schwab, noted the unexpected benefit on tremor, balance, and akinesia or slowness in both Parkinson's disease and in those post-encephalitic Parkinsonian patients. This medication, at the end of the day, it has mild dopaminergic effects, and it enhances dopamine release, at the same time blocking something called the NMDA receptor, which is thought to help reduce dyskinesias, or the extra kind of wiggly movements that can come as a downstream side effect of levodopa. It does have potential for side effects. It can lead to hallucinations, it can lead to confusion, and it can lead to change in skin pattern, something called livedo reticularis. All of these should stop if the medication is stopped. So a few other medications to note, there are the monoamine oxidase type B inhibitors and the COMT inhibitors. These were put on the market in the 1980s and the 90s. The MAOBIs include rasagiline and selegiline. And the COMT inhibitors include entacapone and tolcapone, as well as the more recent opicapone or Ongentys, uh, which was the latter of which was approved as an adjunctive treatment for Parkinson's disease in 2020. Basically, these medications all slow down the breakdown of dopamine in the brain, though just in slightly different ways. We're always producing dopamine, always breaking it down. By inhibiting these molecules that break down dopamine, we allow for it to last longer and have more sustained benefit. So just to briefly touch on a few other medications that are on the market, there are combination therapies like Stalevo that was approved in 2003. There are extended release amantadines like Gocovri that hit the market in 2017. There's inhalable levodopa like Inbrija that hit the market in 2018. There are more novel medications like Norians, which is an adenosine type 2 receptor A antagonist that hit the market in 2019. And then there's scored levodopa like Divi that hit the market in 2021, which has just got its deep score to make it more easy to break the levodopa and to get smaller quarter tab doses. So not just dopaminergic medications have been pursued when treating Parkinson's disease. There are non-motor symptoms to be addressed as well. I don't think we have time to run through all of the non-motor features of Parkinson's disease, but I think the one worth noting is a medicine called pimavanserin or Nuplazid, which is a 5-HT2A inverse agonist that was approved by the FDA in 2016 for psychosis associated with Parkinson's disease, so patients with hallucinations. This is a very helpful drug. It has very few side effects. There were limited options available for psychosis and hallucinations prior in Parkinson's disease, and that all of them can have some impact on dopamine production, with something like Seroquel or clozapine being what we would more likely use in the past. But Nuplazid has this benefit of not affecting dopamine production, so it's something reasonable to start a bit sooner when hallucinations and things are quite mild to prevent them from going on to becoming problematic. So I think from that point, it's worth going on to the surgical treatments. So in the early 1900s, surgery for movement disorders was pioneered by someone named V. Horsley and his engineering colleague R.H. Clark. They developed early stereotactic equipment to target brain nuclei, though their early surgeries dealt with mainly hyperkinetic movement disorders or fast movements like essential tremor rather than Parkinson's disease, the primary hypokinetic or slow movement disorder. In the late 1930s, three neurosurgeons, Dr. Busey, Dr. Case, Dr. Clem, they all excised this cerebral cortex in order to try and treat Parkinsonian tremor, stop the tremor, but unfortunately, this type of ablative surgery caused hemiparesis or weakness on that side of the body, and that type of procedure was ultimately abandoned. Later, another surgeon named Dr. Myers, he first focused on this basal ganglia as a lesion to target for ablating Parkinsonian tremor. In the 1940s, he noted that rigidity improved as well as tremor when that area was targeted. So in 1953, by accident, a surgeon, Irving Cooper, he cut out the anterior choroidal artery during a surgery in a Parkinsonian patient and was forced to ligate it to prevent a hematoma. The unexpected and pretty remarkable relief of tremor and rigidity on the contralateral side led to more widespread use of this procedure, though again, back during this time, the mortality for a procedure like that was upwards of 10%. So later, electrical coagulation procedures involving the globus pallidus, the thalamus, something called the ancilla lenticularis, these were all tried in the 1950s with varying degrees of benefit, varying degrees of side effects. So ultimately, the role of surgery then was kind of eclipsed by levodopa when it came in the 1960s, and there was a pretty long hiatus when surgery wasn't extensively used or pursued in Parkinson's disease. So during this time, however, more advanced surgical techniques were developed in other areas, and these innovations were later applied to Parkinson's disease, kind of more near the end of the 20th century. Some of these treatments date to the contemporary period and include pallidotomies, and later subthalamic nucleus ablation and deep brain stimulation to the thalamus, the pallidum, and the subthalamic nuclei. So deep brain stimulation, right? This is the main surgical intervention that's pursued today. Medtronic was the first company to receive FDA approval for its DBS system to treat tremor in 1997. It received FDA approval specifically for Parkinson's disease in 2002. And then within 10 years of being approved in the United States, over 40,000 people have been treated with DBS for Parkinson's disease or essential tremor. And DBS had gone from being a marginal therapy kind of out on the fringe to a very effective, standard, accepted treatment for Parkinson's disease that we consider very commonly in our movement disorder clinic today. In 2016, St. Jude Medical, which was later acquired by Abbott, they received their FDA approval for their Infinity DBS system, which featured directional leads, allowing for more precise targeting of the brain structures, potentially improving the efficacy and reducing side effects, which we definitely see improvement when we can target. In 2017, Boston Scientific entered the DBS market with FDA approval of its Vercise DBS system. The system introduced advanced programming features and a rechargeable battery designed to last longer than other conventional systems. So overall, the technology for all these companies has improved over times with things like local field potential monitoring, rechargeable batteries, imaging guided stimulation, remote programming for people who can't come into the office. So this is ever evolving, and I expect continued many advancements in the years to come. So this is just an idea of what these devices look like. These pictures are all pretty outdated specifically, but now they're all on devices like Apple cell phones or Samsung cell phone that people have at home. For the sake of time, I don't think I'm going to go into the basal ganglia anatomy, but this is kind of looking at the direct and the indirect pathway, which is part of what we're targeting with deep brain stimulation. And mainly targeting the subthalamic nucleus in Parkinson's disease, the globus pallidus interna, more so in dystonia or patients with lots of dystonia in their Parkinson's disease, and something called the ventral intermediate nucleus of the thalamus in tremor patients. Okay. So DBS, again, this is the main surgical treatment that's used today for Parkinson's disease. As we said, DBS was approved in 2002 as an adjunctive therapy in reducing some of these symptoms of advanced levodopa-responsive Parkinson's disease that are not adequately controlled with the medication. So again, it's important that people respond to levodopa before this be considered. How does it work? Basically, one or more electrodes are attached to leads that are implanted in the deep nuclei of the brain, with these electrodes then connected to an impulse generator that's in the chest, kind of similar to a pacemaker, that delivers this electrical stimulation to the brain tissue to disrupt patterns of neural signaling. So who's a candidate? The best candidates are those that respond well to levodopa, specifically that have on and off fluctuations, times where they look really well, but times where the medications aren't working at all. They can have dyskinesias when they're on, and they can have, or medication-resistant tremor can be another good time. And they all, really, patients who pursue this should have some reasonable cognitive function. We usually avoid this with severe non-motor symptoms. So patients with dementia, patients with unstable mood disorders, patients with severe autonomic dysfunction, blood pressure fluctuations, things like that, as well as those with patients who had a very poor levodopa response, or patients with evidence of an atypical Parkinsonism. We likely wouldn't pursue this in that setting either. So clinically today, the way this is done to have this DBS procedure is patients follow with their movement neurologist first, and there's a discussion kind of regarding DBS. If there's interest, then we usually do what's called an on and off evaluation. The patient will come in on their medicine. The patient will come in off their medicine. We perform this full evaluation called the UPDRS. We look for, again, definite improvement with the medicine, but potential side effects. And then potentially we'll consider neuropsychological testing if needed. Usually a multidisciplinary team will kind of weigh in on all this, including the neurologist, the neuropsychologist, and the neurosurgeon. And then there are two stages to the surgery. The first, the electrodes placed. two potentially small holes are drilled and the electrodes are inserted down, again, most commonly into something called the subthalamic nucleus. Patient is then closed up. 2 weeks later, they go back in, and that impulse generator is placed with the wire that runs under the skin up to those electrodes. Then usually 2 weeks after that, the patient will come back and see a movement disorder doctor in the office, at which point he or she will program that DBS. Usually we get pretty good benefit just right out of the first programming session, but this is further refined and fine-tuned over the following months. So all of these stimulators now come with a controller. We looked at some of the older versions before, now again, in things that look essentially like an iPhone or a Samsung device or a little Windows device. All of these stimulators, you can potentially adjust the settings at home. So normally we'll come in and we'll set the parameters in the office, and then we can educate patients on how to make some of these changes at home if they need to. So I think this is worth looking at if this works. This is an example of DBS for a patient who's on and then off and then on again.
DBS for DT.
It has been about 9 months since you had your STM DBS implanted.
Yes.
What have you noticed since the implantation?
The tremors have disappeared almost entirely. I haven't had medication since about 11:30 last night, and it's 10 o'clock now, so I've been almost 12 hours without medication.
Okay. Do you hold your arms in front of this?
This patient with Parkinson disease enjoys nearly complete control of his Parkinson symptoms, but when the bilateral STM DBS is turned off, marked rest and postural arm and leg tremor and bradykinesia emerge. These symptoms instantly improve when the DBS is again turned on.
That turned off the DBS, and I'm already seeing recurrence of the tremor.
Get that command, am I right?
Okay, let's turn you back on to see how long it takes for the tremor to disappear. Instant.
Yes.
Okay, then hold your arms in front like this now. Next to your nose. Hold your arms down. Okay. Tap your arms even.
Okay, so
DBS for
okay, so I think that kind of just summarizes how effective a treatment like DBS can be, and show that we have certainly come a long way from hanging devices where people are hanging from the ceiling or from bloodletting. I think that's probably a pretty good place to start wrapping everything up. I hope this was helpful for people. I hope everybody stays positive out there. There are good treatments for Parkinson's disease. There's lots of research going on. Things are continuing to advance, and my expectation is that things will hopefully move quickly in the coming years and that more and more treatments will be available. So thank you all very much for your time and attention.
Thank you all for joining us today, and a special thank you to Dr. Joseph Imbs for your informative and insightful presentation. Your experience has it's given us a deeper understanding of the evolution of Parkinson's research and care. This webinar has been a unique opportunity to learn and engage as part of the Independent Parkinson's Network. We are proud to be a part of this incredible community. We are dedicated to education, to collaboration, and support for those impacted by Parkinson's disease. Thanks to everyone for your time, for your participation. I want to again thank our sponsors, AbbVie, Acadia, AskBio, and Blue Rock. And I want to thank my IPN colleagues. We look forward to seeing you all at future IPN events, and I hope that you all have a great rest of your day.
Thank you, everyone. Take care.
Bye.